Targeted therapy is, I think, finally coming of age in myeloma, and targeted therapy in different forms. We talk about precision medicine, and when we first think about precision medicine, we think about drugs which can actually target the biology of the disease. And specifically, precision medicine is a big word in the solid tumor world, where we are targeting specific mutations. Well, we're doing that in myeloma as well. We've just published our experience in JCO Precision Oncology, wherein we've used a BRAF inhibitor in a small subset of patients who are BRAF positive, and we've been able to use single agent Vemurafenib in these patients, and they've had protracted remissions. The next step here would be to look at other mutations, and when you look at multiple myeloma and the mutational burden and the mutational load on myeloma patients is, BRAF is uncommon. It happens in 4 to 6% of myeloma patients, but there are other mutations in the MAP kinase pathway. These include the NRAS mutation and the KRAS mutation, and it's about 20 and 20% of these. So 40% of multiple myeloma patients at the time of relapse are going to have these mutations. So what we're doing currently now is a step forward from our Vemurafenib basket trial. This is a trial where we are using other BRAF inhibitors, in this case Dabrafenib, in addition to a MEK inhibitor. Now, a MEK inhibitor will work in patients with NRAS and KRAS mutations. And what we're using with Dabrafenib is a drug called Trametinib. These are being combined or used alone depending on your mutational profile. So understanding your genotype, understanding your mutational profile in myeloma is becoming incredibly important. And if patients have one of these mutations, we can be smarter about treating them with some of these targeted agents. There are other examples in myeloma where we're using some of these tools to better design treatments. You've heard at this meeting data on venetoclax, which specifically targets the 11-14 translocated myeloma patients, and that's another example of more so precision medicine. But I'm going to take a step back here and say, the monoclonal antibody era, the CAR T cells, etc., is also one form of personalized or precision medicine, because you're going after a target. With CAR T cells, we're going after BCMA. With some of the monoclonal antibodies we've used, we've gone with, we've done CD38 and so on and so forth. So all of these strategies are more targeted approaches, which makes them more precise than chemotherapy alone. So I think we have to broaden the definition a little bit of precision medicine, and I think the future in myeloma is going to be for us to better understand subsets of myeloma and see who benefits from which of these targeted agents.